Hi, everyone, and welcome to this session of uCalgary's webinar series. I'm Deborah Yedlin, and I'm your moderator for today. If you've participated in one of our previous webinars, welcome back. And to all our new viewers, thanks for joining us. We're coming together today to share expertise from our University of Calgary scholars with the community as we continue to navigate the COVID-19 pandemic. Today, we'll be talking about the elusive pandemic peak, the point where rates of infection and new cases begin to drop off instead of increasing. And once again, we're joined by two of our experts in infectious diseases, Dr. Guido Van Marl and Dr. Chris Modi. We'll start with a few questions and then answer questions from the audience. And if you would like to ask our researchers a question, please use the Q&A feature at the bottom of your screen. We'll get to as many of your questions as we can, and this webinar will be available on demand, and we'll email you a link once it's online. Before we begin, I'd like to acknowledge that we're recording this webinar on the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The City of Calgary is also home to Métis Nation of Alberta, Region 3. Now I'd like to introduce our speakers. Dr. Chris Modi is a clinician scientist and professor and head of the Department of Microbiology, Immunology, and Infectious Diseases at the University of Calgary. He's a pulmonologist and respirologist interested in lung infections, and his laboratory performs basic immunology and translational research in the area of microbial host defense. Dr. Guido Van Marl is a molecular virologist and an associate professor in the Department of Microbiology, Immunology, and Infectious Diseases at the University of Calgary. His research focuses on HIV/AIDS and the hepatitis B virus. He's part of a team working on COVID-19 diagnostics. Welcome to you both for the third time. And I just want to say, we started our webinar series with you on the 30th. Your first visit to our series was on the 30th of March. And you had some very dire predictions for us in terms of how we needed to flatten the curve, how we needed to decrease the rate of transmission. And today we're going to be talking about where we are relative to where we were on the 30th of March. Have we seen the peak of this pandemic in terms of transmission? What can you tell us, Chris?
Well, Deborah, thank you very much for asking us to participate in this session and continue to answer questions. That's nice. So, I think the short answer is I hope so, that we've seen the peak. So first of all, let's define the peak. So the peak is the number of cases that we see each day. And frequently that isn't the data that's displayed on the news or on websites where it's cumulative cases. Okay. And so that number is, if it's cumulative cases, that number is never going to go down, whereas the peak is a number that goes up and then comes back down. And so that number is cases per day. And it really looks like that we've turned the corner and the number of cases per day is coming down. But I guess I have a couple of cautions, and that is that, we're starting to lift restrictions. We might talk later about the impact of lifting restrictions and what that's going to do to the curve. But in particular in Alberta, we've seen that clusters, individual clusters, and the most notable case is the meatpacking plants, could add 1,000 cases to what's a total of 4,000 cases, or a bit more than that in Alberta. So these individual clusters can change things a lot. And when those clusters present all the cases within 3 or 4 days, we might actually reach a new high because of one of those. So that would be the caution. But in general, I think Albertans have done a fantastic job. They've adhered to the public health measures, and yeah, we've turned the corner.
That's definitely a far cry from the message that you told us back in at the end of March. So, can we just talk about those individual clusters for a second? Those are big numbers that you were talking about, and how concerned are you about being able to control further outbreak in those areas, whether it's in the meatpacking plants or also in the seniors' homes?
Well, so as we know, those packing plants have reopened, and they're taking appropriate precautions, and the lessons that are being learned at Cargill, which was the first one, are being applied to the other meatpacking plants. And so, I'm optimistic that we've got on top of that. Of course, I haven't actually been to the meatpacking plant myself, and so, but I trust that AHS has been in there, occupational safety has been in there, and there's lots of work being done to ensure distancing, wearing masks, taking all the appropriate precautions. We just did it, and we know that anything that happens in COVID, you make a difference now. 2 weeks later, you get to know whether it was enough or too much. And so we're in that window now, waiting to see whether it was enough or too much. So that's really where we are. I think everybody thinks so. And, I started to think, so can I predict the next industry that sort of has workers in close approximation that would be at risk? And I must admit, I had a little difficulty there. I suppose, work sites where there are camps and people, not necessarily working, not a lot of people working together on a rig, but at least in the camp, so we need to watch out for some of those and start to think about, how to protect workers in those kinds of locations. Socially, I think we've got a handle on that. We're not going to go and have a festival someplace that would expose a large number of people together all at the same time. So I think we've probably got a handle on that.
So Guido, just curious as to your take on whether the province was premature in allowing businesses and other services to start reopening.
Well, that is, of course, the million-dollar question. It's like, are you too soon or too late? Or are you going to be too soon, or do you need to wait longer? Looking at some of the other countries, such as like Germany, New Zealand, Switzerland, Austria, and Iceland, where they're really on their way down, and you see them open up. We're still at the numbers, we're still heading towards, or we're just at that peak and going down. Of course, the question comes up from if you lock it down much longer, how much difference is that going to make? That is a bit hard to predict. But if we keep we could maybe relax a number of the things that we're doing, not just opening up straight away from, okay, as if nothing happened. That's not going to work. Right. So, but really having good testing, having good protocols in place, and that the people so far have been really good at participating in social distancing and other approaches. So if you apply those appropriately, then this might actually just be the right time to do it. Looking at Sweden, where they haven't done, have done a weird sort of compromise between we do some restrictions but not totally. Are they going to get over that hill, or is that a better approach? It's hard to predict. They still get cases. I think here, if we keep following or being cautious, our procedures, and being mindful on what we're doing, doing it really strategically, it might be the right time to do it.
I'm glad.
But we also need to be aware that you might get a second wave, and then we need to, snap back pretty quickly.
So I'm glad you mentioned Sweden. I guess the question is, like, they've taken a different approach, thinking that the approach that they've taken will get them to a herd immunity situation faster. I guess the question is, are they doing it faster with their population at risk? And are we basically trying to manage getting to that herd immunity in a different way? Is that a fair way to characterize what they've done versus what we're doing?
So with their herd immunity, is like, we hope that people will get an immunity because they're getting exposed. If you lock everybody up, nobody will get exposed. Right. Nobody will, you wipe out the infection that way. Nobody has immunity, so you would be maybe susceptible to a new wave of infection because only a small number of us might have some immunity in there. That's a little bit hard to predict if that's the right approach or not. We will have to wait and see how that pans out. Because you will take the risk of that you endanger a lot of people at risk in risk groups, but we will have, if you protect the appropriate populations that are at the highest risk, that might work. But it's also an economic question.
Sure.
Yeah, but it's also a way of a culture and a behavioral thing, because it could be, there is no restrictions, but unconsciously people follow those restrictions anyway by themselves, because they have less contact with people rather than, so there's a lot of cultural practices or ways that different countries deal with things. Like in China, people wear masks also during other flu seasons. So that might actually help. And in other countries, people have a lesser tendency of doing that, and that might be maybe to a detriment. So that is sometimes hard. It's country to country specific.
Chris, do you have anything to add?
Well, I think, I guess the comment I would make is herd immunity has a little bit of a bad, bad rap. In the sense that people have asked the Dr. Tam about that, and she basically said that there's no chance that we're going to consider herd immunity in the equation. And I think really the reason for that is because we're so far from herd immunity. I mean, if you look at the number of people that it takes in the population to achieve some kind of barrier between those infected and those exposed, so that all of the immune people in between intervene in that spread, which is really what herd immunity is all about. The challenge is that you probably need 50, 60, 70% of the population immune. And the problem is we're so far away from that that we really just can't consider it under the present circumstances. If we were to generate a policy to target that specifically, we would go back to a situation where we would be in risk of overwhelming healthcare. So there are ways to do that in a strategic way, and that is what you do is you target segments of the population that are not going to suffer from severe disease in terms of getting you close to that target where you're going to achieve herd immunity. But until you get to, so obviously those are younger people who are not going to likely have to go to hospital in the ICU. So you can do some of that, but I don't see that anybody in the world has really taken on that strategy as a primary motivation. And it's just because, at least in Alberta, we're so far away from getting to that point of herd immunity that really the issues of healthcare on one side and promoting the economy on the other side, have driven the agenda.
So just a question, somebody's joining us from Glasgow, and he says that they're in the 7th week of a lockdown. Public cooperation with limitations on freedom is waning, and government messaging is that lockdown may be eased soon. This is giving license to those who want to see restrictions eased. How does this compare to the experience in Alberta? There are fears that an early lifting of restrictions will cause a second wave. I guess it's a balance point.
Yeah. So I was waiting to see if Guido wanted to
yes, this is based on some of the numbers that people said, that there's still a vast majority of the people that were still in support of the lockdown. But there is, of course, the economic, it's understandable that people, especially if if your jobs are at stake, that there is less support for those things, or you want to can we get going, but can we do it carefully? And I think that, I think the common thing is that people say we don't want to run unnecessary risks. So I think that if we are all behaving appropriately and being cautious, then that support for a slow opening up will probably be good. But it's hard to predict. We have to be cautious. That's all I say. Have to be careful, because if it hits us again, we're going to go back in a lockdown again, and that is so. If we do our thing, then we can keep that lockdown away.
So we know
and that's where I see it. But that's
so, and that's the messaging certainly we're all getting. You know, we're going to do this slowly, because if we don't, we could end up back to where we started. So the question is, we know we'll continue to have cases when the economy does open up.
Yeah.
But what's the acceptable number of cases per day to continue with this strategy? You know, is it going to be 20 cases? Is it going to be 50? Is it going to be 70? Like, what's the number that we're prepared to live with, and that doesn't put the rest of the population at risk?
So we've seen those curves, and I think that, you know, the top of the number that you don't want to get close to is the capacity of healthcare to deal with cases. And so, you know, we've seen numbers that, you know, 300 in that kind of, you know, 300 hospitalized patients in that kind of range. Right now, I think the statistics that I looked at last night were kind of around 50, 70, in that range. We've been in that range. We've been as high as 90, but we've got some capacity before we start to, you know, really have to ramp up healthcare and start, you know, shutting down additional areas and reorganizing medical teams and all of that. So I think that there's some extra capacity, and people are following that, you know, if not hour by hour, certainly day by day. I mean, I get an email every day talking about in-hospital capacity, how many in the ICU in the whole Calgary zone, split out by hospitals, you know, so people are tracking that to say, are we lifting too quickly? And, you know, that's about all we can do. Testing is a good indication of that as well. But, you know, it goes back to my comment before. You make a change, you wait 2 weeks to see whether you were right or wrong. And so, you know, the idea is to operate on the cautious side of that.
So it's interesting because, you know, the percentage of positive tests in the last 5 years is 2.9%, triple the rate of what it was in March of 0.9%. So if our percent positive rate is going up since the lockdown, why do you look at the peak being down? How much does that have to do with sort of the Cargill factor, I guess? Just wondering about how you look at those numbers.
So I guess so I just looked it up right now, and so last night there were 56 patients in hospital confirmed with COVID-19 across all the hospitals in Calgary. So that's, you know, that's a number that's down. Yeah. You know, cases, I mean, you have to, we have to look at cases for what they are. If you, when we have expanded testing, the more you look, the more you're going to find. And so it doesn't necessarily indicate that the process is different. And, you know, if we test everybody and they have mild disease and don't need to come to hospital, then, you know, that's going to be a big number, but the impact on healthcare and, you know, detriment to people's lives is more modest than it is if we're sending people to hospital and into the ICU.
So taking a look at those numbers in the early days when we weren't rolling out testing as massively as we do now, then you get those difference in those numbers. So looking at the numbers that we have now might be a better reflection of what's happening. But yes, we still have to be cautious. That's all there is to it, to be honest.
And are we testing enough? I know, you know, we're hearing Ontario isn't testing enough. Is Alberta truly testing enough to keep a handle on what's going on?
So I think we are. I think that the risk of testing everybody, there's two risks. So the first is if you get a negative test today, that doesn't mean that on the weekend you're not going to be positive. So, you know, it's kind of a question of, so if we start testing everybody in Alberta, Now the question becomes, so how often do we have to test them to know that they're actually negative? And the answer is, at a frequency that's unacceptable in terms of what we're going to be able to provide. That's the first thing. And the second thing is, as you test more and more, so we know that the test isn't perfect. So there are issues of what we call false negatives. So that is somebody that has a negative test who actually has the disease. False positives, when they have a positive test, when they actually don't have the disease. Yeah. And as you test more and more and more people and asymptomatic people, you skew the statistics strongly in favor of false positives. So that person actually doesn't have the disease, but they have a positive test. And now you need to know what to do with that. So do you tell somebody, okay, so we've got a positive test, but you don't have any symptoms. Do you still need to go into isolation for 14 days? And, it just presents all kinds of problems. So personally, I'm in favor of testing people that are symptomatic or are in contact. So, asymptomatic testing had a great role to play in cargo. We know that, but that's under specific circumstances. I don't think that we should offer it to asymptomatic people throughout Alberta. I think we're just going to see false positive tests and having to deal with that. Right.
Are you comfortable that the protocols are standard throughout the province for the testing? Are there inconsistencies in terms of the diagnostics that are being used? Are you comfortable that variable is fixed, so to speak? And so that you don't have to worry about inconsistencies in terms of testing and outcomes? Or are the false positives and false negatives a function of protocols that aren't standardized and diagnostic equipment that's being used that isn't the same?
So I'm unaware of any concerns about variability in the province from site to site. That hasn't come onto my radar. There are issues with the person who's obtaining the samples. And so for those of you that have had a test done, if you get a nasopharyngeal swab, it's an uncomfortable process because they go right to the very back of your nasopharynx, and that you feel like they're, some people I've heard describe it as, it feels like they're scratching the inside of your brain. The other test that's being done now is an oral pharyngeal swab, which is more like a standard throat swab, and that's not nearly as uncomfortable, still associated with gag, as the other. And then there's another test so all of those require an operator. So somebody actually has to hold the swab to do the test. There's another test that's been evaluated in Hong Kong and in China, and that is what's called an oral lavage, which is basically a gargle. And the test results with that are fairly positive. And so probably as good as the other tests, but you do have to be sure that people gargle properly. And so that becomes, not technician dependent, but actually patient dependent. Can they gargle properly to do that? So we haven't implemented that test, but it is another test that might be in some hands even more acceptable than a swab in the back of your throat.
Some of us of a certain generation remember being encouraged to gargle with salt water. Yeah, it was one of those fallbacks. Another question: just has immunity after exposure been confirmed? Are we still in that process of figuring that out?
Well, we know that people make antibodies, and that those antibodies can be neutralizing. To see from if people are being reinfected, that is the big question. There are some people that we see the disease pop up again, but the question there is it actually they never cleared the infection, and it's basically a persistent infection that pops up back back up again. With regard to some of the experiments that people have done with vaccines, there is some where they did, I thought it was African green monkeys, where they used an inactivated virus, and the animals were protected after a challenge with the SARS coronavirus 2. So, but you know how good the immunity is in everybody, we're still sort of confirming that and figuring that out.
So if you're immunocompromised, is your only option to wait until there's a vaccine for you to be able to go outside and resume your life? Or is this really a function of being comfortable that there are therapeutics that can address the illness itself and keep it under control so that you can resume your prior existence, so to speak? Could one of you take that question?
Okay, so if you're like if you have an immune or immune compromised, then the question is like from how good, if you get vaccinated, how good will the vaccine be to in you, but also if we have appropriate antivirals, so actually that we can block and people are working on those, you know, so if you get positive and we treat you early enough, then we probably can keep you out of, so if those things come along too, then that would be good news for individuals in those categories too. Chris, you want to reflect on that a bit more too, from a clinical perspective?
I think that's good, you know.
Okay. I guess a follow-up question though, but does that mean if you are immunocompromised, your life's basically on hold until there is a vaccine?
Or good antivirals.
Good antivirals, okay.
Yeah, so it's not just, so we need to have additional tools in the tool shed to tackle this disease.
Yeah, I guess I wouldn't like, so personally, I'm not advising my patients that are immunocompromised to stay home all the time and never go out. Yeah. I don't think that that's good for them. You know, and I think it's reasonable to have a conversation with them and assess the risk, and for them to balance the risk, and for me to try to help them to be as safe as they can when they're out in society. You know, those are important things. And, you know, and we know the public health measures: wash your hand, don't touch your face, physical distancing, you know, all those sorts of things. The mask is more important in terms of protecting you from spreading it to someone rather than you acquiring it from someone. But, you know, so talking yesterday to a patient who's immunocompromised and saying, you know, what do I do? And I said, I want you to go out for a walk. I want you to take your dog out. I want you to go with your partner and, you know, and enjoy the sunshine and do all of those things. You know, I think you want to avoid getting into crowded situations and doing all that because you are at risk. And, you know, interestingly enough, I was reading a study last night about heart transplant patients and, you know, what are they doing? And it actually turns out, so they do get a more severe disease if they get it, but actually the incidence of disease in those patients is less. And it's because they are so careful about living their lives. They wash their hands, whereas, you know, other people, they might not be 100% adherent to that. Right? So, you know, I think immunocompromised patients are pretty careful, and if they do that, then you know, you actually see less infections.
Because they face this every day, even during regular flu season or a cold season. So, yeah, so there's multiple things that can work in your favor there.
So just, Chris, you just mentioned something, you know, they wash their hands. So a lot of people have acquired new hygiene practices, so to speak, as a result of this. So do they stick, or do we just toss them when the challenges disappear from this virus spreading?
So so It's an interesting question, Deborah, and I think the answer is that good hygiene is the appropriate way to go.
Right.
But I was reflecting the other day that we've gone to an era where people somewhat jokingly say, well, I'm diversifying my microbiome. And it's a euphemism for, if I don't wash my hands, or I, pick something up off the ground, or if I, do something like, so you drop something off the table and, the 8-second rule or something like that, that we used to joke about as a kid, now we use the phrase, we're diversifying our microbiome. So I was reflecting the other day, how we're going to balance those, because we know a diversified microbiome is important, and living our lives in literally a sterile bubble is not good for us. And so I think we're going to see a number of studies coming down the pike where we're going to see how do we actually balance that. And so do we manipulate our microbiome using additional dietary supplements, or how do we do that while maintaining hand hygiene to avoid viral spread? It's going to be a fascinating issue. And the wonderful thing, it's not the area of research that I work in, but the wonderful thing is that Calgary is a world leader. I mean, probably among the top 2 or 3 institutes in the entire world in microbiome. So we're poised to answer that question. So I look forward to the answers that my colleagues are going to come up with.
Did you have something to say?
No, it's the the balance between playing in the dirt or not.
Right.
But it is good hygiene. You protect yourself from a lot of nasty things out there that might not be from the manage of COVID or for in that realm, but it's definitely a good hygiene is very appropriate.
Right.
So we're talking about things opening up in Alberta. It's pretty apparent that there are more cases in Calgary than there are in Edmonton by a huge factor. Should the easing of restrictions be province-wide, or should they be by region based on the number of cases? What do you think?
Do you want that one, Guido, or do you want me to?
No, doesn't matter, whatever.
Okay, so I think that the historical perspective is, we started off with cases that were repatriating Albertans, and a lot of those came to Calgary, and that was responsible for that early peak. There's a self-perpetuating nature to an outbreak like COVID-19 or any infectious pandemic or otherwise. So you have a case, and that's more likely to spread to another case, and that's more likely to spread to another. So once you get the ball rolling in Calgary, you're going to see this perpetuation of cases. And so we've seen that. And then on top of that, the third layer is that we've seen the effect of clusters like at Cargill and GBS and other meatpacking plants. And so we've started to see the effect of that. So at each round, we've said, well, there's a reason why we're seeing more cases in Alberta. At a first step, what do we do about restrictions? Do we lift them province-wide, or do we say, oh, we can lift them in the north, but better be a bit more cautious in the south? I think that the first round of lifting restrictions, it's fine to lift them province-wide. But in the second round of lifting restrictions, I think what we're going to see is we're going to say, oh, this restriction is probably too much. We need to back off a little bit that, basically put the restriction back on partially. And then other restrictions we're going to start to see lifting. And so there's going to be more precision applied to how the restrictions are lifted. And we might see more restrictions. So nothing, no increasing restrictions in the north, perhaps, and lifting more restrictions there. In the Calgary, we'll probably see some lifting of restrictions and some reapplying restrictions in other areas.
Might have people taking the QE2 going to get a haircut in Edmonton.
Well, that would be counterproductive, I would say. But,
That's a good question. What about provinces set to resume daycares, as early as the 14th of May? What are your thoughts on children as super spreaders? Is that something that you're very concerned about?
It's a bit hard to say if the kids are really super spreaders. We do know that children get infected. In general, most of them get mild or not as serious disease, but if they are a major driver of just by themselves because they produce more virus than an adult, that is hard to say. It's more also, again, the behaviors that, large group, big group, smaller groups, other hygienes and other appropriate measures that will affect that. That will be hard to sort of predict in that sense. That based on the data, I haven't seen anything unless Chris has some other information on it.
No, I think that's right, Guido. I think the way I look at it is, children are an ideal population to lift restrictions. We know that, statistically, they don't suffer from severe disease. Of course, they can, but there have been very few patients at the Alberta Children's Hospital, fortunately. There are some for sure. And so it's not completely safe, but in terms of lifting restrictions in a way that doesn't burden the healthcare system, children are a good population. The problem is who they're in contact with. And so, children don't live in a society by themselves. They're in contact with the parents and grandparents and elders and all of that. And so that's the population in the more advanced stages that we need to protect. And so good idea to do it for children, but they still can spread the virus to somebody else, even if it's not a super spreader. And it's the elders that we need to protect.
Right. So there's been some interesting studies that have been trying to draw a line between smoking and COVID. Do you have any comments on the relationship between, smokers and the prevalence of people getting the disease? Are they more vulnerable or not? There was initially it was, it sounded like a lot of the people who had been afflicted by the virus were male, over a certain age, and were smokers. That seemed to be the narrative that we were hearing. And what's the reality? Do we know enough?
So go ahead, Guido.
Some of the things that I've been reading, and then people say, oh, it's nicotine. Of course, when you smoke a cigarette, you don't just inhale nicotine. You do a whole bunch of other things. So that would be hard to say is there a protective effect? It's a bit hard to make those distinctions at this moment in time. So Chris might be, as a pulmonologist, a little bit more aware of these things. But also, it's like there are other factors that also maybe make particular people more represented in a particular population, because maybe due to other activities, those people were more exposed or less exposed. So that's also a little bit hard to figure out. The same as the stories about the blood type. Yes, there is a host susceptibility. So we know that from infectious diseases, one person might get more disease than another disease, even though they're infected with the same virus. The one study that says there was a link with blood type, there's another study that says there is no link between that. So we're still also with those things, we need to go much, much deeper to what is underlying that. And if that's really, really the case. Chris, you want to reflect on the smoking?
Well, I guess the comment that I would make is the same comment that I give to my patients. And I say to them, we know that cigarette smoking damages lungs and predisposes to infections. We know that vaping causes lung injury, and that lung injury can be either chronic or can be acute and even fatal. And that lung injury, when lungs are injured, they don't deal with infections very well. And so I say to all of them, I want you to quit smoking, strongly advise you to quit smoking during the time that COVID-19 is active in the community. And, they say, well, how long is that going to be, Doc? And, the answer that I say is, it's probably going to be until the end of the summer. And then they say to me, so if I quit till the end of the summer, I might as well quit for good. And my response to that is great, great. But if you can't quit, then at least set that goal for the end of the summer and say, I'm not going to touch another cigarette. I'm not going to vape until the end of the summer. And if you can accomplish that, then you've protected yourself during COVID-19 as much as you possibly can. And so, I've had some buy-in from patients from that strategy. Of course, there are some that just, they just can't quit, and we've, tried everything else. And of course, I, use all of the different medications and patches and gum and inhalers and everything else to try to help them to quit. And all of those things have shown to be efficacious. But, so we try to do that until we're done COVID-19, because I think it does put them at risk.
Are you more worried about vapors versus over smokers, or are they both in the same bucket for risk?
So what we know is it's different, right? So smoking, in general, wide generality here, smoking doesn't kill people right away, whereas vaping does. And so, and there's also, I think we're learning that there's a chronic form of vaping injury as well. And so it's more subtle, like the effect of cigarette smoke. And it's different than cigarette smoking lung injury. But, previously I used to say to people, well, if you have to smoke, consider switching over to vaping, and at least that way you can use that as your nicotine delivery system, right? And I don't say that anymore because I'm worried about vaping.
So from a testing perspective, I guess one of the questions is, when we get back to normal, does that mean that there has to be testing done at places like the university for all staff, faculty, for students? Will there be temperature measuring devices as you walk into classrooms, or if you walk into the Students' Union building? And I guess more broadly, should we be expected that our temperature will be taken when we go to a Flames game one day? Is this the new normal for us going forward? Or is it still until we get a vaccine and then we can sort of start to think about things a little differently?
I think testing is, of course, our good weapon, and how we will deploy that on a bigger population when we get back to work. Those are things that we will look at. Measuring temperatures at the door will probably catch the person that is already symptomatic. So hopefully you can also get people, if you have symptoms, stay home.
Right.
You might have somebody in the asymptomatic phase that you might not pick up anyway. So you can argue about that, but a more strategic deployment of testing in particular environments where a lot of people are together, that might be something that might come, but that's something that I would not be able to reflect on directly on how we would envision that.
Yeah, I mean, my comment would be, so there's no perfect way to do that. We've talked about some of the issues in testing. In general, it's pretty good. In general, temperature is pretty good, but there have been some criticisms of temperature as well. In terms of this, temperature can be taken non-invasively. So, when you walk into a Flames game, you could have your temperature checked and you not even know that you're having your temperature checked, just like it's done in an airport. And then, somebody would then approach you and say, you realize you have a temperature. What should we do about that? So there are ways to do that. I don't know that there's going to be any perfect way. And I like Skito's suggestion of we need to have a culture where if you're feeling sick, you stay home.
Right. So no more bravado of coming to the office if you have a cold.
that was not appreciated anyway if you had a
That's
regular
all I know.
cold. So that's so I think we should be, without shaming people, of course, but it's more like from be a bit more cautious on that route too.
So there's something this question's come up, and it was one of the ones that was on my list, and it has to do with children and their the fact that they're presenting more with Kawasaki's disease. Is it linked to? Is there evidence that it's linked to COVID-19? And maybe also talk about what that is exactly, because I'm sure a lot of people don't know what Kawasaki's disease is.
Yeah, sure. So, so Kawasaki's disease is a type of heart disease in children, and it's we see it very, very rarely in adults. I think in my whole career, I've seen less than half a dozen cases of Kawasaki's in adults, but the pediatricians certainly see it more commonly. It's a disease that you can see as a consequence to just about any viral illness. I don't know that there's anything that isn't on the list. And so now COVID-19, with the very high degree of scrutiny, as people have realized that that's on the list too. And so it tracks a little bit, with the anosmia that people have, so inability to smell things. I mean, that's not unique to COVID-19 either. But there's a big difference between Kawasaki's disease, which has very significant consequences for children, and not being able to smell for a couple of weeks. So it's important that practitioners know about it and recognize it. And there is a whole list of other processes that occur: skin diseases, liver, hepatitis, a whole panel of different things that we're seeing described in COVID-19.
So it's more that they have symptoms that look like Kawasaki disease, or certain aspects of the disease that are observed in some of the COVID patients. But I think if either the two of them are linked, like 100%, like Chris said, there are many other underlying causes for that.
Right. So there's a couple questions that come in that can get one together. So will contact tracing be the most effective way of making sure that we can keep the population safe and managing the impact and timing for the second wave, but also connected to that is we've had this Alberta tracing app that was launched. So is this the way to manage and identify and look at the cautionary measures that we're taking? These two, can you talk about that? And how effective?
Okay. Do you want me to have a stab at that, or?
Yeah,
Okay.
if you could.
Yeah, so contact tracing is a very important way to control the number of cases that you're seeing. So basically, with perfect contact tracing, if you knew every case that was infected, contact trace them, make sure that those people aren't infected, and if they are, put them in isolation, trace all their contacts, and basically what you do is you stop the chain of infection. And so, to get into a term that I think we'll probably get into a little bit later, is the issue of the R0. You make the R0, the transmission factor, go to zero. Okay? And that's the goal of contact tracing, is to make the R0 for that particular, outbreak, cluster, whatever you want to say, that local case, the R0 for that particular virus and that particular person goes to zero. The transmission stops. And so, that's the role of contact tracing. Okay. The app that we've recently seen, and, I downloaded it, the moment it was available, because I'm interested in doing that. And I would encourage other people to do the same. Unfortunately, I have an Apple phone and it doesn't work particularly well on an Apple phone. You have to keep your phone on and the screen lit up in your pocket for it to actually work. And so that's a little bit of a challenge. They're trying to work on the fix for that, but in an Android, apparently it works much better. And so, we're working on that, but I think it's a good way to know whether or not you're in contact with somebody that subsequently tested positive the next day, or 2 days down the road. So, there's some advantage to using it. I don't have any concern about people knowing where I am. That's okay, but you know, I appreciate that privacy is a big issue, and they're trying to sort that out. And you know, at a national level, I know that Dr. Tam is watching very closely what's happening in Alberta to see what happens to that app.
Mm-hmm.
Yeah.
Go ahead, Guido. Did you have something to add?
No, that's about it.
So, you know, some of us have, you know, there's no end of information about what's happening, of course. And of course, we saw that there was a study published that the virus has mutated to become more contagious. A, is that actually been proven? And B, how worried are you about this process for finding a vaccine? Does that compromise the ability to find a vaccine that's effective?
Okay. Yeah, so a lot of us have been watching that study, and that study, so far what they found is just purely like, we see a particular type of virus that is now more common than it was at the beginning.
Okay.
And there is no direct evidence that the one is more contagious or causes more disease. And there's a lot of debate about it because it's based purely on the sequences, on the genetic material, that is not based on any biology that anybody has tested. Things like that, viruses mutate. That's a fact of life. That's what they will do and continue to do. That's the way how they survive and also avoid the immune systems. Now, compared to some other viruses, coronaviruses are less mutagenic in that sense, but it's also, is the mutation actually a bad thing or a good thing? There's different schools of thought too, is that it even could mutate to something that's more benign rather than being something that is totally bad. We need to figure that out. But that data that's available, they notice is an interesting thing, that there is indeed a difference, and this different virus seems to be becoming more predominant. Now that could have many, many different explanations, nothing to do necessarily with being more contagious. It could be that some more people were infected with that variant, or it is a new introduction from another source that then takes over because more people are infected with that, and those are the ones that are spreading it. Well, the other virus is not being spread because those people are in isolation, and so it dies out. And so those are difficult questions to answer, but people are looking at that also with regard to vaccines, looking if it is actually an important site that changes. We see that with flu, the flu changes all the time, so you have to make new vaccines to prepare for the next outbreak. So what I could see that it could mean for vaccines is that we have to constantly keep changing it the same way as we do for flu. And so that it may not be, we're just very cautious with it, we're paying way more attention to these things now, but that's what I would say from at this moment in time. It's a very good observation, but what it actually means, we don't know. But we're cautious, of course.
Right. So can you give us any insight into treatment breakthroughs? We see a lot of things in the news. What are you seeing that offers some promise in terms of a therapeutic that can help us, mitigate the impact of this?
So that's a great question, and I think the first comment that I want to make is that there are still a lot of really important trials that are occurring now. And one of the things that I see is that a particular antiviral therapy gets a certain amount of press. People perceive that that viral therapy has no real advantage. And despite the fact that the data isn't really solid, now they don't want to enroll in a clinical trial that includes that agent. And so I think that we really need to have solid answers for what works and what doesn't work. And so, for example, I think that the information for hydroxychloroquine doesn't look particularly promising right now, but we don't have that really big study with thousands of patients in it to know whether or not hydroxychloroquine has a positive signal or not. And we need to do that trial, and we need people to enroll in that trial so that we have that answer once and for all. Because right, as it stands now, the drug is relatively inexpensive, available, and people are going to want to use it if there's a chance that it might work, and it's not without side effects. On the other side, there have been some really more promising studies about remdesivir. That's an intravenous medication, and I think that those studies look pretty good. But I saw a study out of China, a few days ago, and that study, while it failed to meet its, its number of target patients, and so consequently it was what's called underpowered. That study, it's hard to imagine, even if they'd been able to meet the number of patients to be adequately powered, that would have been a positive study. So while there are some positive studies, there are others that are not. And so, that yet again, we need some really robust studies to test that. And then there are the other, 4 arms, well, 3 arms that are in the Solidarity trial that look at a variety of other antiviral agents, and we need these answers. So I think the message to people is, if you're unfortunate and you get COVID-19 and you get sick with it and somebody approaches you for a trial, please consider enrolling, because that's the way we're going to know the answers.
One of the things we're grappling with, of course, is as we open up, how do we protect ourselves against getting the disease? You mentioned that masks protect the wearer from transmitting. So, in places like, whether it's hockey arenas or the university, how do you protect yourself against someone else who may be sick but not wearing a mask?
Well, I think the answer is, we've talked about, how the importance of hand hygiene, the importance of not touching your face, the importance of social distancing. Those are really the ways to do it. Short of some kind of an approach, and we don't have the literature to say, so is there a prophylactic antiviral that you could take? So, is there, and we're way away from doing those studies. I mean, nobody's that I've seen even talking about that. Is there a pill you could take on the way to the hockey game that would prevent you from getting it, right? I mean, we do that with other things. If you have valvular disease and you go to the dentist, you take an antibiotic before you go, right? So, that is a strategy that people are familiar with. And so that's a possibility. The antivirals, we need that. We need immunity, whether or not that's natural immunity or whether or not it's vaccine-related immunity. We need that, and we need to know that those that the immune response that we measure in a disc or in a tube actually reflects protection, as Dr. Van Marl talked about earlier.
Just a final question. Is it safe to be in other people's homes, friends and family who are in our social bubbles? You're starting to see people really starting to itch and wanting to connect with others. Is it too early to do that? Or can we start thinking about that as long as we're comfortable that the individuals that we want to connect to have been following the same practices that we have?
Guido, I'll let you do that one.
So that's the hard one again. But if it is that if we all play by the same rules,
right,
then that and even that, like seeing each other and keeping appropriate distances without having to ignore anybody, there's probably ways of doing that really carefully. But that's. So it's some of the things that we will have to also wait and see. We have to be very cautious and keep our eyes out and just be, follow the appropriate rules like face mask or whatever, if that's the way it has. And like are you sick? Are you not sick? I'm feeling sick, please don't come.
Right.
Or I'm not coming. That's, right. Some of those are very simple things to do. And that should be our sort of our gut response now.
Well, on that note, I'm going to say that's a more hopeful note. I want to thank both Chris and Guido for sharing their insights and answering our questions. As I mentioned earlier, everyone who signed up today will get an email with a link to view the session on demand. And join us, please, for our next webinar when we speak to Peter Tertzakian, economist, investment strategist, and best-selling author about Canada's energy transition. We will doing that. We will be speaking about the future of Canada's energy sector on May 14th, so that's next week. In the meantime, you can find more webinars and other content by visiting ucalgary.ca/COVID-support. And if you would like to support our research into COVID-19, you can visit ucalgary.ca/giving day, where you can choose to donate to Student Relief or our COVID-19 Research Fund. Thanks very much for joining us today. See you next time.
Thanks, Deborah.
Thanks for being there.
Thank you.